So let's break down some differential diagnoses for both problems. If we find out that the problem's in our peak pressure and it's a resistance issue, some of the things that immediately go through my head, first and foremost, is a mucus plug, okay? If I've put a big ball of mucus either into the endotracheal tube or into one of the major airways to where it's nearly or completely obstructing part of the lung, the ventilator is going to have to give a lot more air to get past that new piece of resistance in the airway. Once it bypasses the mucus plug, once airflow is established past it, it becomes very easy to inflate the lung, which is why the plateau pressure is low. But think mucus plug, okay? Other things that can happen. If you have somebody who has an underlying airways issue to begin with, asthma or COPD, they can go into bronchospasm. These are large airways that clamp down. The bronchi squeeze down, the ventilator's got to push air past it. Once it opens it up, again, it becomes easy to inflate. Okay? The extreme example of this is your status asthmaticus patient who will have such tight airways that the ventilator can almost not even get past what's going on in the airways obstruction, and you may not deliver any tidal volume. In contrast, some of your COPD patients have underlying floppy lungs to begin with, a very high compliance system, so you'll see a very high peak pressure and then a very low plateau with large tidal volumes once the ventilator is able to bypass the spastic airway, okay? It's strange to think about, but tube kinks, whether mechanically done by the patient, by biting down on the tube, or just in the hustle and bustle of turning a patient in the ICU, oftentimes the ET tube can become kinked, or even one of the tubes from the vent circuit can develop an obstruction in it. All of that will look exactly the same. So when you're checking on these patients, make sure that the ET tube is open, there's no kink in the tube. If there's not a bite block in the patient's mouth, make sure the patient's not biting down on the tube. And if all else fails, sometimes you do actually have to put a bronchoscope in these people in order to just directly visualize the ET tube all the way down. Usually if they've got a mucus plug or you're suspecting they have a mucus plug, you're going to be putting a bronchoscope in them at the same time anyways. Looking over here now, let's talk about things that can affect lung compliance, because frankly, these are more of the correctable pathologies that you're going to run into. Most of the time when it's something like this, it's a quick fix, with the exception sometimes of bronchospasm. So, things that can affect the plateau pressure. Certainly a lot of your ARDS patients or your pulmonary edema patients are going to come in with poor lung compliance to begin with. And there's a possibility that the underlying pathology has just gotten worse. So, obviously, if they have pulmonary edema, you're going to be diuresing these patients. But if they have ARDS, that's not always going to be the case. Either way, you want to try and rule this in some way, usually with chest imaging. If there's a large change in what the parenchyma look like on a chest x-ray, you might be able to chalk it up just to worsening of their underlying pathology. Most of the time, these things will happen slightly more gradually than some of the other problems as well. A very serious pathology that we keep in the back of our heads when there's a sudden change in lung compliance is pneumothorax, okay? Now, without getting too far into the stepwise changes that happen during a pneumothorax, you will have an initial pop of the lung where it becomes very easy to push air into this chest cavity, and then as the lung continues to deflate and becomes less compliant, you're going to have an increase in intrathoracic pressure and a functional decrease in lung compliance. Usually if it gets to that point, you're also experiencing some tension. If the patient is what we call fighting the ventilator, or trying to breathe dysynchronously with what the ventilator is doing, you'll see sometimes that they bear down with their abdominal muscles at the same time as the ventilator is trying to give a breath in. Bearing down with the abdominal muscles increases intrathoracic pressure, which makes it harder for the ventilator to push against it, manifesting in a decrease in lung compliance. The way around this is usually to sedate your patient a little bit deeper, or potentially paralyze them if it gets to that point. I have a very low-tech test for whether this is happening. Usually I'll just go in and I'll put my hand on the patient's belly and watch them breathe. And if I can feel them tense their abdomen up and breathe against that ventilator while I'm looking at the ventilator screen, when the ventilator's trying to push a breath in, I get an idea that they're probably fighting the vent. Sometimes the patient will also give you additional tricks that they're or additional hints rather, that they're under sedated. If they're trying to take breaths when the vent's not giving them, or what they're calling breath stacking, some other things that we'll go into another time. All of those things can be solved with either sedating your patient deeper or potentially paralyzing them if you can't sedate them deeply enough. Last thing I'll just mention is this concept of air trapping, okay? It does end up manifesting as an issue with lung compliance, but because air trapping is related to somewhat different pathologies, it can happen in other ways. I sort of think of it by itself. And this is that concept of what you'll hear of called Auto-Peep. Auto-Peep, to put it simply, is a trapping of air that occurs inside the system because the patient's not allowed to completely exhale before the ventilator gives them another breath. So if you can imagine, this is no longer a pressure curve, this is going to be a volume curve over time. But if I give a patient a breath, and then I let them breathe out, but before they're finished breathing out, I start giving them another breath, well, my ventilator's not smart enough to know that I've still got some air in the circuit. So if I set this breath at 400 cc's, and then I start a new breath here, well, it's going to want to deliver another 400 cc's. And if I don't breathe out all the way again and I breathe in again, I'm going to give it another 400 cc's. And you can imagine, as the lungs eventually have a maximal capacity, that this is going to build up pressure within the circuit, okay? And so this will manifest on a pressure curve as a breath on top of a peep, then a breath, and then that peep is just going to get a little higher, and you'll see that the peak pressures go up, the plateau pressures go up the same way, until eventually you run into that upper alarm. Okay? The solution for auto-peeping in its most extreme scenario, where it's causing tension physiology and the patient's hypotensive, is to actually just unplug them from the ventilator and let all that pressure drain out of the system for 5-10 seconds. You plug them back in and go from there. If you have time, and you can tell that they're air trapping, you can tell that the pressure's building up in the circuit, but it's not so extreme yet. Most of the time we're buying this back by lengthening the amount of expiratory time the patient gets. This is most often seen in our COPD patients, where they might have an expiratory time of 6, 7, 8 seconds before they get another breath going in. Eventually, again, as the pressure builds up, this will cause an increase in peak and plateau pressures because, again, it's that peep. We talked about increasing the peep, increases all those pressures. You'll see a high plateau, but it's a problem with air trapping and auto-peep. So again, the fix for that, disconnect them from the ventilator in the extreme scenario, or lengthen that expiratory time out. When I see any of these things come up and I've gone through, I've figured out based on my inspiratory hold what's going on with the patient, I'll then start thinking about the underlying problem. Often I'm ordering a chest x-ray at the same time because chest imaging is really helpful to help differentiate between some of these different things within knowing whether it's a pump compliance or a resistance issue.